My name is Dr. Shital Shah from Singapore General Hospital, and I shall be speaking on T for aortic valve assessment. And I thank Dr. Kanchi Murlidhar and the entire organizing committee for this opportunity. I do not have any conflict of interest, and the outline of my talk will be quite simple about the anatomy and morphology of aortic valve and the TE evaluation for this. The normal aortic root, it consists of aortic valve annulus, the three cusps, sinuses of Valsalva, two coronary ostia, and the sinotubular junction, as you see from the diagram here. The three aortic valve cusps, they are similar in size and morphology, and their name is achieved, or the nomenclature comes from the respective coronary ostia. So left coronary cusp is left coronary ostia, right coronary cusp is a right coronary ostia. Each cusp has a valve body, a coaptation surface, and a physiological hinge point that attaches the cusp to the annulus and gives it a semi-lunar appearance. The cusps open in systole, and it gives an equilateral triangle. The common aortic valve cusp variant, the most common is bicuspid, which is shown in the bottom of frame, systolic and diastolic. Quadricuspid, systolic and diastolic frame on the left side, and the unicuspid. But I guess the pathologies associated with this will be discussed by further speakers. Node of Arantus, it's a common anatomical present at the center of the valve leaflet. It's more like a fibrin material. It increases in size with age, but has no clinical significance. Similarly, lambus excrescences, they are a filamentous structure present on the undersurface and very, very rarely associated with any cerebrovascular incidents. In comparison, the differential diagnosis is the papillary fibroelastoma, which is the primary tumor of the heart. They are very commonly associated with the cerebral events. PE evaluation, four main views for the aortic valve evaluation: mid-esophageal aortic valve short axis and long axis view, transgastric and deep transgastric long axis view. We start with the mid-esophageal aortic valve short axis view, obtained in the mid-esophageal level by rotating the multiplane angle to something around 30 to 65 degrees. And you see the three leaflets, tricuspid aortic valve. The cusp that is nearest to the interatrial septum is a non-coronary cusp. That the distal most towards the right ventricle is the right coronary cusp, and the third one is the left coronary cusp. At this point, if you withdraw the flow image or the probe a little bit, you can come at the level of sinus of Valsalva and then slightly antiflex the probe, and you will be able to see right and the left coronary ostia. The main advantage of this view is to assess the aortic valve area by planimetry, color flow Doppler to assess some aortic regurgitation points. And this advantage is application of spectral Doppler, as it's not parallel with the blood. Increasing the multiplane angle to something around 110 to 150 degrees, you see mid-esophageal aortic valve in a long axis view. The cusp that is distal most toward the right ventricle is the right coronary cusp, whereas the cusp which is near to the anterior mitral leaflet, it can be either a non-coronary cusp or a left coronary cusp. So how to find it? One, either you go back to short axis view, you center your image and focus it either the left cusp or the non-coronary cusp, and then increase the angle by 90 degrees, you will see the respective cusp in the long axis. Or you can apply the X-plane. The main advantages here are application of color flow Doppler to assess the aortic regurgitation and do the root measurements: aortic annulus, sinus of Valsalva, ST junction, proximal ascending aorta, and also the LVOT. Application of M mode is another advantage, and disadvantage is same as that of short axis view of application of spectral Doppler, since it's not parallel to the blood flow. This chart shows the normal indexed values for annulus, sinus of Valsalva, sinotubular junction, and proximal aorta. Annulus is measured in mid-systole, inner edge to inner edge. Same for LVOT diameter. Sinus of Valsalva sinotubular junction is measured in end diastole, again inner edge to inner edge, since it's a better compliance. Moving on to transgastric long axis view by advancing the probe to stomach and increasing the multiplane angle to something between 90 to 120 degrees. You see aortic valve on the right side of the image. The cusp that is on the left side is the right coronary cusp, and the cusp which is closer to the mitral valve, it can be either non-coronary or left coronary. Sometimes you may have to tilt the probe a little bit to the right so that it gives a good alignment for the continuous or a pulse wave Doppler for assessment of velocity and gradients. Disadvantage, sometimes it is difficult to get this alignment right. And then going on to deep transgastric long axis view, advancing the probe further by 50 up to 50-60 cms, anti-flexing the probe, and then a very slow gradual withdrawal gets you the deep transgastric view. And as you see again, the left side of the cusp, the left cusp in the view is the right coronary cusp, whereas the cusp that is always near to the mitral valve, it can be either non-coronary or the left coronary. The advantage here, again, it's a good alignment for continuous wave and pulse wave Doppler so as to assess gradients and velocities, and then estimate stroke volume and aortic valve area by continuity equations. The difficulty needs some more practice so as to get this view with ease and alignment of the Doppler beam. So our system for evaluation when you are doing, examine the aortic valve for normal 3 leaflets or any congenital or acquired abnormalities. Evaluate each and every individual cusp. Apply color flow Doppler to look for any incompetence. Anatomic or geometric aortic valve area is in the planimetry, which is normal 3 to 4 square centimeters, and the functional or the effective aortic valve area is calculated by the Doppler. In Doppler evaluation, remember the blood flow across the normal aortic valve is always laminar during systole and absent during diastole. If it is present in diastole, that's the aortic incompetence. Or a turbulent mosaic pattern during systole, it indicates acceleration across the narrow orifice, whereas if there is a systolic acceleration proximal to the aortic valve, that will indicate some subaortic narrowing. Spectral Doppler evaluation by continuous wave Doppler in the previous 2 views as shown, as discussed. Remember, try to put a color flow first, see where there is a maximum flow. Accordingly, put your cursor for spectral Doppler and apply the continuous wave Doppler beam. It's a laminar flow in a normal aortic valve, peaking in early systole. And the normal peak velocities across both aortic valve and LVOT should be less than 1.5 meter per second. Applying the simplified Bernoulli's equation, you can calculate the peak pressure gradient 4 times the peak velocity squared. Remember, pressure gradients are flow dependent, so decrease or increase the flow rate will affect the pressure gradient accordingly. And the more common causes for decreasing the flow rate are either LV dysfunction, left to right shunts, or certain mitral valve pathologies. Whereas increase will happen in hyperdynamic circulation, LV function, sepsis, and AR. So, going on to calculation by continuity equation, VTI for LVOT done by manual tracing, sample point 0.5 to 1 centimeter proximal to aortic valve in transgastric or deep transgastric view. Diameter of LVOT, mid-esophageal aortic valve long axis view, same point, 0.5 to 1 centimeter proximal to the aortic valve. Stroke volume of LVOT will be VTI times the LVOT area. VTI for aortic valve done by the manual tracing, continuous wave Doppler, and then aortic valve area calculated by continuity equation as shown, LVOT stroke volume divided by VTI for aortic valve area. Angle of Doppler beam, keep it as parallel as you can. If the angle is more than 30 degrees, that's going to underestimate the VTI and the peak velocities. The last slide is about the M mode application. Because of a high temporal resolution, you can apply M mode across the aortic valve in a mid-esophageal aortic valve long axis view, which gives you a box appearance. The opening to closure of the aortic valve is the LV ejection time. It's an independent indicator of systolic function, and the normal is 362 plus minus 42 milliseconds. All the measurements which we do, whether it's a VTI or M mode, remember, we do it 3 times in a sinus rhythm and do it 5 times averaging in a atrial fibrillation. As a rule, ECG must always be applied while doing a TEE, so that you can, from this mode, you can see if there is a premature opening of aortic valve before the QRS, indicates increased LV pressure, or if it's a premature closure of aortic valve, that's before the T wave, indicates dynamic outflow obstruction. The line of closure is also symmetric. If it's an eccentric one, or think in your mind for a bicuspid valve, short LV ejection time is a decreased stroke volume, long LV ejection time are the increased stroke volume reasons. So in summary, the teaching points for aortic valve estimation and some key points or trick points to remember: complete the examination of aortic valve, entire aortic root anatomy. In mid-esophageal aortic valve short axis view, sector on either the non-coronary first and the left coronary, then increase the angle by 90 degrees to see the respective non-coronary and left coronary cusp in the long axis. The right coronary cusp is anyway easy. It's the bottom one distal one. Aortic valve annulus and the LVOT measurements, they are done in mid-esophageal aortic valve long axis, mid-systole, end-to-end. Sinus of Valsalva, sinotubular junction, proximal ascending aorta, done in mid-esophageal aortic valve long axis in end diastole, end-to-end. If there is a systolic flow acceleration with a color flow Doppler, think about narrowed orifice. If there is a diastolic flow, think about aortic regurgitation. And if there is a systolic acceleration proximal to the aortic valve, think about subaortic narrowing and channel your energy into this to look into more of a mechanism and then management. The normal continuous wave Doppler of aortic valve is a smooth, filled in appearance and peaks in early systole. Velocity is flow dependent. So apply a color flow mode, note the fastest flow and sample here for the VTI for the continuous wave or a pulse wave Doppler. Average of 3 in terms of sinus rhythm, average of 5 in atrial fibrillation. If your angle is more than 30 degrees, that's going to underestimate the peak velocity and the VTI. LVOT diameter measure at about 0.5 to 1 centimeter proximal to aortic annulus. And similarly, when you do LVOT VTI, sample at the same place. Anatomical aortic valve area is a planimetry, mid-esophageal aortic valve short axis view in a mid-systole. Functional or effective aortic valve area is a continuity equation. And the M mode normal pattern is a box waveform, and the normal LV ejection time is 362 plus minus 42 milliseconds. Thank you for your time and attention. I can be reached on the email address shitalkumar.shah@singal.com.sg and also on my mobile WhatsApp. Thank you.